Hello, everyone. Welcome to our first POCUS VMR of the year. We are super excited to have back Dr. Ross Prager. He was with us last year on October, and we like so much his presentation that we invite him to come back. Ross, do you want to say hello?
Hello, everyone. Thanks for having me.
Yeah, last time we asked like what you like to do for fun. Maybe we can ask, I don't know, what is your favorite ice cream? I hope you like ice cream.
I love ice cream. I'm a salted caramel sort of guy. We have a couple great local brands in Canada. Not Ben and Jerry's, although that's fairly close to us in Vermont. But yeah, I know. I'm a salted caramel sort of guy.
Ross, could you also tell people about your Twitter page and what exactly you teach?
Yeah, so yeah, absolutely. So I'm an intensivist, and I'm interested in critical care ultrasound, hemodynamics, venous congestion, and I guess more broadly knowledge translation. So I certainly appreciate the efforts you guys make in knowledge translation and trying to disseminate new education around the world, and that certainly fits some of my own objectives. So thanks for having me.
Yeah, he always has some good insights on Twitter or X now. So I recommend everyone to take a look. Yeah, if you want to start with the presentation, we are ready.
Let's do it. All right. Well, so a bit of background. So, London, Ontario, which is where I live and practice, is a little city here between Toronto and Detroit in Canada. It's a very beautiful city. There's about 500,000 people. It has an excellent university, Western, which the reason I brought this up last time and while I'll bring it up again is we have many fellows from around the world doing various fellowships here. It's a great place to train, very supportive staff, and hopefully some of you will come through London and Western at some point and see kind of what we have to offer here. My clinical practice, I'm an intensivist by training. I did internal medicine before, but full disclaimer, I don't consider myself an internist anymore, and certainly I can't hold a candle to you guys in terms of your clinical problem solving. So I like to keep it pretty simple on this. I want to stick with the bread and butter, but hopefully add a bit of a flavor from some of our experience with critical care ultrasound, and particularly I'm part of a research team that studies AI lung ultrasound, and so we certainly have some insights kind of at a very deep level, no pun intended there with the deep learning on AI ultrasound and lung ultrasound. So hopefully I can share some of those insights. So here's a case we probably see every night on internal medicine. So you have a 72-year-old gentleman. He's presenting to hospital with some acute on chronic dyspnea. He's not really having any fevers, chills, sweats that he endorses. There's been maybe some mildly worsening peripheral edema over the last couple of weeks to maybe a bit longer. Some worsening orthopnea at night, but no PNB. So I know this is a very general kind of stem here, but any thoughts that come to mind and any kind of additional questions you want to ask me and clarify off the bat?
I think I can start. Yeah, like looking for this acute and chronic dyspnea, we always like start with could be the heart, something like a heart failure, like acute coronary syndrome. If could be the lungs, it could be like COPD, asthma, some pulmonary hypertension, and like some worsening on the orthopnea make me think maybe a little bit more for heart failure. So I would ask what like this chronic for how long time the patient is experienced this dyspnea. That's where I would start, and definitely ask more about the past medical history. Robbie, what you would ask?
Oh, absolutely. Everything that you mentioned there, just sort of getting an idea of this person's background. So, how functional they are, how is this limiting their daily work-life balance? How much, is this impacting their ability to do any activity? What have they changed? Have they changed anything in their routine? Have they started any new medications that could maybe contributed to this as well? And like you mentioned as well, any past medical history that could have relevance or any bearing on this as well. Like, so instance, like you mentioned, if the patient has some liver issue or maybe some cardiac issue that could have relevance on this. So getting some background on this and then foreground on this is, does the patient have any exam findings, maybe in the history, something like bendopnea, things like this, that could have a high likelihood ratio for our pretest, increasing our pretest probability for maybe something like congestive heart failure or anything like that. So, and then integrating that in an iterative process, in doing reasoning, doing the exam, and then deciding what kind of data to get and even where to point our POCUS probe at. So sort of those are a few steps there before I would sort of jump in. Back to you, Ross.
Yeah, beautiful. So I'll get you some of more of that information, but let's hop to the past medical history. So there's a question. He reports that there's a history of interstitial lung disease. I'll talk about that a bit more. Heart failure, preserved ejection fraction, some high blood pressure, diabetes, on kind of a normal gambit of medications to control those. He had an echo done a few months ago. Echo report a few months ago showed normal kind of LV function, but then there was a dilated right ventricle, maybe a bit of moderate dysfunction there, some mild TR, elevated RVSP. So his history is he hasn't felt well for a couple of years, he says. His function's slowly been declining. He gets more dyspneic when he exerts himself. There's been a kind of a chronic decline for, let's say, the past year or two. But really, for the last few weeks, something has changed. He's become acutely dyspneic with moderate exertion. He has difficulty kind of going up the stairs at his house. His legs are a bit more swollen. He woke up a couple times in the night feeling really short of breath. And then when he lays down, he also feels kind of short of breath. He coughs, but it's not productive. He just generally feels out of breath. And the ILD history that he had, he says, well, some doctor did a CT scan 6 months ago and it showed this NSIP pattern. I was meant to follow up with the respirologist, but I actually felt okay that week. And like I kind of smoked when I was younger, so I assumed it was just smoking related. So I didn't really kind of follow up at all with that. Um, yeah, he actually still is smoking, he says, but not as much as he used to be, not a drinker. And he worked in like a factory 25 years ago. He was doing some kind of textile manufacturing. And so kind of with that, are there any more targeted questions you'd want to ask about maybe past medical history, social history, exposures, seeing like Streptococcus, like anything like that?
Yeah, well, I guess I'll start, Deborah. I think in his background, like you mentioned, there's smoking history, but if there's any exposure to any other environmental toxins or any other inhalants, what kind of industry did the person work in, or any substances that the patient may have been handling during this time? Say, for instance, automobile mechanic working with brake lining or the linings of brakes, which can contain asbestos, or somebody who's working in plumbing and opening up walls could be exposed to asbestos and so on. So that would be one question. Anything comes to mind, Deborah?
Yeah, like we have some good thoughts in the chat if the patient has any exposure, like any he recently traveled. Some people are wondering about birds exposure. I think that's where my thoughts are.
Yeah, perfect. So he worked in like a textile factory, no exposure to asbestos as far as he knows, no kind of solvent exposure. Certainly recently, he has been compliant with his medications and his blood pressure is well controlled. It's been a long-standing condition for him. He does not fancy birds, as multiple people have asked. This is not a case of bird fancier's lungs, I promise you that. And so in general, he was kind of short of breath, getting worse, not anything particularly localizing. That's kind of the summary here. So if we had to kind of commit before we have history, before we have, or sorry, before we have physical, before we have any investigations, what would be your top three differentials that you would consider for this gentleman?
Good question. I think, as we said, that the patient smokes and if with the dyspnea, I would think about COPD. I would think maybe if the heart failure that he has, if he's exacerbated, and maybe, I don't know, a pneumonia too. That's what would be your top three, Ravi?
I think pretty much along the lines what you've spelt out there. Just the image was interesting. Ross, could you go back to that CT for a second?
Yeah. And this was from 6 months ago. This is a old little CT.
So I was just wondering if there's an extension of this condition. Maybe they just kind of superficially labeled it an NSIP, which I guess could have a prodrome. Smoking could contribute to IPF, but I just kind of wonder, getting another CT, see if this is ramped up and is worse. Although, from what I remember, NSIP doesn't go through the whole honeycombing and so on, the fibrotics um, uh, features that are associated with IPF. You don't usually get that, but yeah, I think again, if this is a lung fibrotic process, and like Deborah had mentioned, pathophysiologically, you do get pulmonary vascular changes, which could contribute to the right heart pressure changes, and then the right-sided congestion that you're seeing in the patient. So it might not be all HFpEF, but it could also be pulmonary vascular changes as well. And then you also have to wonder if there's an acute on chronic phase to this as well. Could there be something acute, such as a pulmonary embolism, contributing to this as well?
Yeah. So great points here. So I will just make a quick comment. So NSIP is a pattern seen on CT scan. It has many different etiologies that are potentially responsible for it. It could be idiopathic itself, or it can have underlying contributory causes. It's characterized by subpleural sparing, as some of you have commented in the chat there. I would argue that there is a degree of kind of subpleural sparing if you take a look at this and kind of follow it along. It's not a specific pattern, so things can change. Things can appear as NSIP initially and then progress to other forms or other patterns on imaging, just as a kind of heads up for everyone. But great points. So yeah, this is kind of how I would conceptualize it as well. It sounds like this patient has either worsening ILD, maybe some heart failure, maybe they have a viral infection, COVID, ARDS, something like that. Maybe they have a bacterial pneumonia. Maybe there is, yeah, I think these are all great considerations, but ultimately we need some more send stuff. So when he came in, actually, he didn't look that bad, but he was quite hypoxic and was actually placed on a non-rebreather, and with that only satting about 94%. He's alert, oriented, has normal kind of neuro exam. He's actually warm, well perfused, has a regular pulse, but he does have this mild pitting edema to his shins. He says, that's been getting worse for a couple months. It hasn't been super acute. He's tachypnic, respirates around almost 30, and he has moderate accessory muscle use. He doesn't look so hot. He's kind of sitting in the back area of the emergency department. You say, hey, why don't we move him up front and take him out of the hallway? I don't know if American hospitals have patients in the hallways, but certainly we do in Canada. So you move him out of the corridor, the janitor's closet, and you put him into a patient care room. Anything else you'd want to know on exam? Yeah.
And the patient didn't have any crackles or in the lungs.
Oh yeah, sorry, I forgot. I don't listen to people's lungs, admittedly. I typically just use ultrasound, so I always forget that is part of the physical. Yes, so you listen and there's crackles. Yes, there are
Okay.
crackles.
Okay.
Yes, apologies.
No, it's okay. Anything else, Ravi? No DVP, no.
JVP,
Yeah,
if
JVP.
it was
Sorry.
seen.
JVP, yeah, not visualized. It never is.
I think what really
Oh,
scares me is the amount of oxygen to maintain sort of normal saturation. And the other thing is the respiratory rate is very concerning as well. So that these are sort of like danger signs that could forecast impending decompensation. So those things do worry me.
I love it. Yeah, great points. So let's get some initial investigation. So the white count's mildly elevated. Platelets, it's meant to be a 145, not a 45. Apologies there. So it's not critically low. It's kind of in the normal range. Hemoglobin's a bit on the low side. Creatinine's normal. Potassium's mildly elevated. The rest of it, the electrolytes are totally fine. LFTs are normal. You can't get a BNP at your center. We don't do BNP at our center here. So ECG has normal sinus rhythm with mild LVH. And then the chest X-ray here, which kind of just because this isn't a chest X-ray, virtual monitor report, this is a lung ultrasound one. I'll just kind of hop in and say that there's bilateral kind of airspace disease, perhaps some increased reticular markings. There's perhaps mild vascular redistribution, perihilar fullness. There's no obvious pleural effusions. So there's kind of just like patchiness on both sides. The radiologist interprets it as consider atypical infection, pulmonary edema, interstitial lung disease, pneumonia. So there's kind of a generic radiology report for something a little bit too white on the chest X-ray. Any other initial kind of emerge investigations you would order right now, recognizing that they might not come back for a few hours to longer, depending on your center? A BNP, nope. The BNP machine in your state has or country has not worked, so no BNPs available for anyone. An ABG, yeah. So the
ABG.
patient's hypoxic, yeah. The patient's hypoxic, normal PCO2, normal pH. Urine studies, I see there for sure, urinalysis. Oh, I guess probably thinking a bit more along the lines of like a pulmonary renal syndrome. So the UA is bland. There's nothing to suggest like a GN or a vasculitis. Awesome. All right. So what treatment would you order for this gentleman while you're waiting for, I imagine people would put in for an echo and a CT chest and some of the other stuff that were already mentioned. What would people do for kind of preliminary treatment here in the emergency department? Some Lasix, I see.
Yeah,
Oh,
I
lots
see.
of
I
Lasix.
see a bunch of people mentioning diuresis, which can be helpful. It can be both therapeutic and diagnostic at the same time.
I love it. So nebs, steroids, diuretics, and antibiotics. I like it. Pulmonary rally pack. I've never heard that term before, but that's great.
I
Yeah,
think it's
so I
also, sorry to interrupt. Yeah, worthwhile also to make sure there's no urinary retention because I've given
mm,
diuretics to patients and then wait for diuresis only to find that they're not producing urine. So also have to make sure there's no urinary retention at the same time that's occurring.
yeah, totally agree. So another comment there on NIV, like the patient's on 15 liters of oxygen, they're tachypnic, they had accessory muscle use. Is this patient a candidate for non-invasive ventilation? Great comments. So I always just kind of feel this is obviously ChatGPT generating this image that when we admit patients to the ICU with kind of dyspnea, sometimes we just throw the steroids, Lasix, antibiotics, the rally pack, as you say. It's not very elegant, but I feel like in practice it happens a fair bit. So we do all of the above. But then the question early, you start thinking, shoot, like, should I call ICU? Does this patient need BiPAP? Do they need to be intubated? And unfortunately, while you're kind of making that decision, they continue to worsen. And I think this is probably a really good place to integrate POCUS because the decision to put somebody on BiPAP versus intubate them is a challenging one, and it certainly has a lot of implications for depending on the underlying disease process. If this is heart failure, we know that heart failure responds very well to non-invasive ventilation, even if somebody looks really sick. But if this is ILD, that's not a process. An ILD flare doesn't get better in the matter of hours to short days. We're really talking about days to weeks here. And so you have to really weigh the risk and benefit. And I think this is a case where we essentially have undifferentiated dyspnea that we think could be heart failure, but equally likely could be ILD, equally likely could be COVID or ARDS right now. And so, but we have to make a decision right now about which direction we're going to go. And you can say, well, why don't we just put them on BiPAP and let the dust settle? Sure. But then you actually limit your ability to get other investigations. You can't bronch the patient, you can't get a CT chest potentially. So there is a diagnostic implications to your decision to intubate this patient. And so I think this is a good case where lung ultrasound can come in. And so we'll just take a slight step back from the case and talk a little bit about how lung ultrasound might be able to help us in this case. So in London and in many centers, we do a 4-quadrant approach to lung ultrasound on each hemithorax. We start on the anterior chest with what we'd call kind of an R1. Then we go into the axilla for an R2. We go at the costophrenic angle for an R3, and then we go kind of really posterior by the bed for a 4th view. With R1 and R2 being our parenchymal views, because they're looking at the lung parenchyma themselves, and then R3 and R4 being our pleural views, because we're looking at the pleural space. And how it looks like on a CT chest is R1 is measuring kind of anteriorly, R2 is measuring kind of mid-axillary or anterior axillary, and we're kind of looking at costophrenic. And R4, you really try to get your knuckles in the bed and you look at that posterior space. And one of the beautiful things about this is ultrasound at where it images the lung has excellent resolution just for the very, very surface of the lung. And if you actually wrap around the entire lung, you almost get like a CT scan like resolution just of the first centimeter or two of the lung parenchyma itself. So you can actually map out the airspace disease pattern, location, and pathology pretty well. And R3 and R4, that's where all the bad stuff for a lot of hospital patients hide. So pleural effusions, they go posteriorly. Pneumonia, often posterior. ARDS, often posterior. So you can get beautiful visualization of the posterior lung fields using the R3 and R4 views. And then R1 and R2 can tell you a lot about the interstitial pattern. And I'm going to talk a bit more about that. And that's where this concept of B-lines comes in. And so many of you, I think, will be familiar with the concepts of A versus B line pattern. So an A line pattern is a horizontal artifact that is generated from the shimmering of the pleural line. So just to orient all of us, again, this is the probe at the surface of the skin. Here's the subcutaneous tissue. Here's the pleural line with kind of two rib shadows on either side. And here's the interspace. And this is normal lung parenchyma, and normal lung parenchyma generate this A-line pattern, which is these repeating horizontal lines that are just artifacts. When there's something in the alveoli, and this could be fluid infection, we'll talk about the different causes, we get this B-line pattern, or comet tail artifact, which are vertical lines originating from the pleura. And this is an important point. They actually have to come from the pleura themselves to be called B-lines, not from a subpleural consolidation. And they typically 2 or more per interspace is considered pathogenic, and they can be caused by various things, but they indicate something is in the alveoli or the interlobular septae of the lung at that probe location. So what actually generates B-lines? So when you scan a patient, the ultrasound beam is going to go down. It's going to hit the go down pleura, interlobular septae, reflect back, and it creates a bit of a harmonic imaging, and you get these nice little horizontal lines, and that's normal. It does that a couple times. You can see here, you get nice little A lines, and they're at repeating intervals, kind of consistent. What happens with B lines? When there's fluid, pus, fibrosis in the lungs, whatever, the ultrasound beam gets trapped inside the interlobular septa in the pleura, and it starts bouncing back and forth. The ultrasound machine figures out how deep a structure is by how long it takes the ultrasound beam to come back. So the longer it takes the ultrasound beam to come back to the probe, the deeper the machine thinks it is. And because it's getting trapped here and bouncing around a whole bunch, it keeps thinking that whatever this bright interlobular septa is deeper and deeper, and it starts plotting them out in repeating intervals all the way down. And when you kind of amplify that all the way down to the bottom of the screen, you get this comet tail artifact, which is really caused by something that is trapping the ultrasound in here. So what causes B-lines? The first thing is infectious causes. So COVID, viral pneumonia, even just regular pneumonia can be one etiology. Hydrostatic, which is I think the one we think of the most, B-lines and decompensated heart failure. High left atrial pressure, transmitted retrograde into the pulmonary veins, transmitted retrograde into the alveoli, actually filling them up with pulmonary edema. Then there's inflammatory causes, so ARDS, infectious or otherwise, interstitial lung diseases causing inflammation, and even diffuse alveolar hemorrhage can cause B-lines. And the last is fibrotic. Actually, patients with chronic pulmonary fibrosis can have B-lines. The question is, can we tell the difference between these etiologies on kind of visual inspection? Because that would be really helpful. If you could look at a B-line and be like, this is heart failure versus this is pneumonia, that would help add a lot compared with chest x-ray. The short answer is you kind of can. It works in some cases, but not all. But there's certainly some things to dive into here. So when you have an infectious B line, it progresses from left to right. So this is a normal interspace. We have the A line pattern. You have multiple B lines here. They suddenly become more and more confluent as the kind of airspace disease, and you start seeing these subpleural consolidations here as well. And then eventually you completely just fill in the entire lung space with pneumonia. And you get some bronchograms in here. And so one thing that you can do if you think that this is an infectious B line is you can kind of get the sense of the burden of B lines reflecting potentially the burden of the underlying disease. There's also different phenotypes of B lines. So on the left here, this is a patient with heart failure. The features that make it appear to be heart failure on lung ultrasound are the fact that there's a smooth pleural line. There's innumerable B lines. If I asked you to count how many B lines here, you'd probably be like, I think I can see 6. No, that's 10. You'd all say a different number. They're extremely difficult to count, and they're not discrete. They don't feel like they're tethered to that pleural line and they're stuck and only moving with the pleural line. They have this playfulness. They dance around. That is very hallmark of hydrostatic B lines. When you look at the B lines on this patient, though, you can see that the pleural line is irregular. there's this small area of kind of irregularity, this hypodensity in the middle there. There's also these B lines here, and it's hard to count. They seem to really be stuck to the fibrotic, they seem very stuck to the pleural line themselves. Again, a hallmark of an infectious or ARDS or fibrotic B line here. So look at the pleural line, and then look at kind of the degree of mobility and fluidity of the B lines. That seems to have some prognostic implication. There's also thought about measuring the distance between B lines, and that's been studied with the idea that whether or not the fluids in the alveoli, like in heart failure, compared with if it's more of like an interlobular pattern, there can be different appearances of B lines, but that's not something that I routinely do in practice. So focusing on the pleura here, I'm gonna maybe just involve you, Deborah Ravi. How would you comment on what the pleura appears like for the one on the left? Is that smooth pleural line, irregular pleural line? What do you think?
Want to try, Deborah?
No, you can go.
Oh, okay. Yeah, definitely looks fractured and definitely not smooth, but you definitely do see lung sliding, although it's split up. Yeah.
Exactly. So there's clearly lung sliding. There's this shimmering of the artifact without a doubt. But as you say, it's lumpy or disconnected, and that's because there's these tiny little subpleural consolidations. So this is classic of something like COVID ARDS, where you get these tiny subpleural consolidations. And so if I saw this in a patient with acute kind of white chest X-ray, no past medical history of ILD, I would be strongly suspicious that this is an inflammatory infectious B line as opposed to hydrostatic. What about this one? So that is an irregular pleural line. What about this one here? Would we say that this is regular or irregular?
I think definitely looks more regular than the one on the left, but there still are some which look like septations, and even I see a little subpleural um, abnormality there. Yeah.
Yeah, just on the left side of the clip there. I totally agree. It still is irregular. There's thickening to this pleural line. There's subpleural consolidations. So this is also an irregular pleural line. Tricky here. But great job. These are very, very useful. So that's the first thing I focus on. The next thing that you can do, and this is getting a little bit more advanced here, is let's turn away from the lungs and actually look at the heart. Because if we're trying to figure out whether or not something is kind of infectious, inflammatory, or what we could say is non-cardiogenic, that should have normal left atrial pressure. But if somebody has really high left atrial pressure, which is the cause of hydrostatic B lines in heart failure, then we should be able to measure that. And it's actually not too hard to measure on ultrasound. Bear with me here for 1 second. So we're going to look at two markers, the E and then the E prime. So this is an apical four-chamber view. You'll have to believe me here, it's not the best image here. So in an apical four-chamber view, you're going to look at the flow into the left ventricle from the left atrium during diastole. And this is the E wave and the A wave. This is a normal diastolic filling. And you can just measure the top. You don't have to measure the deceleration time. That's just an incorrect label. You just measure this value. So this is 1 meter per second or 100 centimeters per second. The stiffer somebody's ventricle is, faster their ventricle has to fill. So think about a very smooth, compliant ventricle, a healthy person. There's actually low velocity of kind of inflow. But as the ventricle becomes stiff, it all fills at once as this stiff thing pops open. We get high E's. When we look at the E prime, this is actually now using something called tissue Doppler, where we're looking at the velocity at which the actual muscle of the heart relaxes and contracts, but we're going to focus on relaxation. And so when somebody has diastolic dysfunction, their heart relaxes more slowly. And so the E prime velocity, which is a measure of relaxation during kind of the diastole, the non-atrial part of diastole, is low. And now if we compare those two and add them together, so you go the E, which is how quickly the blood is going in, and the E prime, which is how quickly the muscle's relaxing, so E over E prime, if you divide those two numbers and then add 4, that's actually a pretty good estimate of left atrial pressure, with left atrial pressures above 14, 16, really indicating potential hydrostatic edema. So in these undifferentiated cases, this is a great way to say that, I'm quite suspicious that this is going to be hydrostatic from heart failure as opposed to infectious. Other thing that you can do is look for other company in the lung. So again, that lung base, that R4, R3 view, it really tells you a lot about pleural effusions. And if you see bilateral pleural effusions in addition to B-lines everywhere, it may increase your post-test probability that this is hydrostatic. And then the history, and I think you already alluded to this. So if somebody has no infectious symptoms, if they have a history of ILD or no ILD, and they have low suspicion for inflammatory causes, then it's most likely hydrostatic origin. Sorry, it should say if there's no infectious symptoms, no history of ILD, and you have a low suspicion for inflammatory causes like ARDS or ILD, then it's most likely hydrostatic. Common things being common, most B lines in patients without lung pathology are cardiogenic in origin. Similarly, if you trial a therapeutic thing like diuretics or CPAP BiPAP and your B lines quickly resolve, which they can in the matter of kind of half an hour to an hour to 2 hours, that will also suggest that is more likely heart failure. And the last thing is deep learning for B lines. So this is a study that our group did actually before I joined, but essentially looking at B lines in COVID patients, heart failure patients, and non-COVID ARDS. And to the human eye, some people can distinguish between heart failure and COVID, heart failure and non-COVID. Nobody can distinguish between non-COVID and COVID ARDS, but actually the AI model can distinguish between them pretty accurately and can discriminate quite well. And so really, I think AI is a potential application to solve this and actually tell you what the etiology of the B lines are, more so than kind of the human eye, because it can detect those small subpleural irregularities, other patterns of the B lines that we just can't quite process. And for those of you that aren't as familiar looking at AI models, on the right, we have heat maps, which are explainability, and they essentially tell you where is the AI model making the prediction based on. And so you can see here for COVID, a lot of it's related to that pleural line there. And so there seems to be some difference in the pleural line that really helps differentiate these B lines between different etiologies that perhaps as humans we might not be able to appreciate, but certainly an AI model with deep learning can. So back to our case here. So this is what we see. Let's go with the clip on the left. So what do we think? Irregular or irregular? Everyone put unhappy face for irregular, or like an angry face for irregular, and a smiley face for regular. Yeah, unhappy. Love it. So do you feel personal assessment of? Yeah, great question from Brett there. So the question is, can you actually rely on the B lines enough to not throw the kitchen sink at somebody with acute undifferentiated dyspnea? It would depend on your pretest probability. Any test in isolation, you shouldn't be basing your entire treatment off of, but it's certainly one piece that could move you towards not adding antibiotics. So if I have a patient with no history of no history of ILD, low pretest probability for suspicion for inflammatory lung disease, they present with bilateral B lines with a smooth pleural line, I feel pretty confident that that's heart failure and not any antibiotics unless there's something else on history. But if the patient has a history of ILD, I would still consider maybe adding steroids or antibiotics depending on the clinical history. So, yeah, great question. Ultimately, this is an irregular pleural line. And what's going on this one on the right here? So unhappy face if you think there's a big subpleural consolidation, and happy face if you think that there is a pleural effusion. Yeah, so sad faces. I agree. Very sad face. So this dark area is an example of a large subpleural consolidation. These can be caused by infectious causes, inflammatory causes, ARDS. They can be caused by PEs even. And not that this presentation is in keeping with the PE, but agree, this is not a smooth pleural line suggestive of heart failure and much more likely is related to some sort of infectious or inflammatory cause. Which, now going back to our case, in the context of our ILD, what does this make us think? So what would we reclassify our differential diagnosis as, and what would be the next steps here? And maybe for the next steps, I would specifically tie, would you BiPAP this gentleman or intubate them? Deborah, Ravi, any comments there?
Sure. Could you go back to the patient's image?
Yeah, so irregular pleural line with subpleural consolidation.
Subpleural. So then we're looking at something more infectious along the line, um, rather than just hydrostatic, like you mentioned the categories. So in this case, this patient, we probably, if we're thinking heart failure, then CPAP, BiPAP. But if we're thinking something more nefarious like COVID, and this patient's working hard to breathe, I would go ahead and intubate the patient, maybe get more high resolution imaging if we can before that, maybe a
I love
CT.
that. I love that. And I think that's what I wanted to really highlight with this case is we're really at a crossroads for this patient. They have either heart failure or what I'll call non-heart failure stuff like ILD, infectious, COVID, whatever is going on there. But you are kind of at a therapeutic decision point because yes, you can BiPAP people and lay them flat in a CT scanner, but depending on your setting, that may not actually be the best thing for the patient. Some patients might not even tolerate it; they could deteriorate in the CT scanner. So having some idea about your pretest probability that this is heart failure, because if it's heart failure, just leave them in emerge for another 8 hours on BiPAP and then take them off BiPAP and send them home, sort of thing. Like these heart failure patients resolve so quickly. And so I totally agree with your rationalization there that if this patient has features of non-cardiogenic pulmonary edema or non-cardiogenic B lines, that's probably not something that's going to resolve within the matter of hours to short days, which BiPAP lends itself particularly well to. Um, so I agree that depending on the clinical situation, this might push me towards intubation. And this is just kind of a plug from my ICU side that really non-invasive ventilation is best for single system respiratory disease that's going to resolve in the next couple days. COPD, heart failure, less so for diseases like pneumonia, less so for diseases like ARDS. COVID is kind of that weird exception where the RecoveryNet non-invasive trial showed that CPAP potentially was beneficial for COVID patients, even to prevent kind of intubation and ICU deterioration. Just something to keep in mind. So we get the CT chest that everyone kind of was hoping for the whole time because we've intubated them now, so we can actually lay them flat and get the good quality CT chest that we need here. So how would you describe this CT chest if we could now? Yeah, fused ground glass,
Ground
more ground
glass.
glass. Totally. So there's diffused bilateral ground glass opacifications here. There's maybe not the same features of subpleural sparing. There's not any of the honeycombing sometimes that we expect with UIP pattern and IPF. I agree. So this looks infectious, inflammatory. So what would be your diagnostic workup from here now that the patient's intubated, mechanically ventilated? Let's say you repeat an echo, the echo's normal. Any other specific blood tests or investigations you would want to perform?
Probably get a respiratory panel. See if
Perfect.
there's, yeah.
And when you say respiratory panel, is that for kind of viral etiologies
Yep.
or non-viral infectious etiologies as well?
Pretty much the gamut of respiratory viral infections.
Perfect. Yusuf asked a good question. Does anyone have a problem representation? Which I think would probably be helpful here. Um, does anyone want to summarize how they would consider their, yeah, how would you conceptualize this? So and I know the history's been a long time ago and we didn't write it down, so maybe I'll provide a bit of a history here. So maybe I'll do the problem representation. I guess I could do that. So we have a 72-year-old gentleman with a possible history of ILD and heart failure with preserved ejection fraction, who's suffered a acute on chronic, months going on to kind of weeks, worsening hypoxic respiratory failure with ground glass opacifications bilaterally. I'd say my kind of provisional diagnosis is either an ILD flare or a infectious decompensation of some sort, potentially viral, or a typical infection with less likely hydrostatic pulmonary edema owing to the kind of lung ultrasound and also our recent echo that's been negative. Nice. Austin's was better than mine. I should have let him just go there instead of, but thanks for sharing that. So I totally agree. So I'm going to read it out. Middle-aged man with ILD and heart failure, preserved ejection fraction in his 60s, presenting with chronic progressive respiratory failure with acute worsening, now with profound hypoxia and CT showing ground glass opacifications. And the patient was never on chronic steroids. They never followed up with their respirology appointment. All right, so we're going to do a BAL. We're going to send for viral panels. We're going to send off all the infectious causes that we can think of. We're going to do a CRP or ESR. Any other autoimmune or serologic workup you would order for this gentleman? Serum quant. What's a serum quant? That's probably a different abbreviation than what I'm used to. He's not on chronic steroids. Yeah, so an ANA, ANCA, anti-GBM. I'll add a C3, C4, maybe a rheumatoid factor, CCP, just kind of the normal HIV kind of chronic workup that we often send. Anything else? Ooh, quantiferon gold. We just have those TB skin tests in Canada, so we don't have anything fancy like that. Perfect. All right, so let's do a bit of a resolution here and hopefully a few take homes. So the first is that this patient was eventually extubated. They actually got a provisional diagnosis of ILD flare from possible new diagnosis of IPF. And it's interesting, the CT scan 6 months ago showed what looked more like an NSIP pattern, but then on evolution over this case over the subsequent months to short years, there actually started to be some honeycombing. So this may have been an early catch of an IPF diagnosis. There wasn't any clear exposure or autoimmune cause for it. He was discharged from hospital actually on home oxygen, but weaned off of that in a couple months at home. Maybe there was a viral cause of this acute decompensation and acute on chronic kind of thing. Maybe it was just an ILD flare of some sort. So we're not entirely sure. Couple take homes though. So the first, differentiating A versus B pattern is hugely powerful at the bedside. You can have a patient with acute dyspnea and you can tell whether or not this is COPD or heart failure if those are your two leading differential diagnoses within seconds. Highly recommend. You can go beyond that though. You can actually look at the B lines and look at the pleural line. Are there subpleural consolidations, pleural effusions? What's the clinical history? And then potentially even diastology, and break that down further into, are these B lines cardiogenic in origin or non-cardiogenic? And theoretically, this can have implications for acute management, decisions surrounding airway support, ongoing diuresis and decongestion. A good example is if you have a gentleman with ILD or a patient with ILD with kind of bilateral B lines, but maybe they're actually quite hypovolemic because they have concurrent pneumonia and they actually need fluid resuscitation as opposed to decongestion. This could be one potential way to help sort that out. Unfortunately, physical exam is quite insensitive in differentiated etiologies of interstitial syndrome that are seen on chest imaging. And so really we have to rely on other technologies. And I think ultrasound is a promising one that we can use at the bedside. And with that, I welcome any questions. And I'll throw a little shout out to a knowledge translation platform I'm working on called SimpleSage. It's at simplesage.io. It's helping researchers perform high quality, efficient, and impactful research. So we have some tools that we're developing there. You can essentially use some AI protocol checkers, manuscript checkers that you can upload your paper, and then it will tell you what kind of reporting guideline you should be using, and then it'll cross-reference it with kind of known reporting guidelines. So we're building some more tools just to help researchers and clinicians, but I certainly welcome any input people have here on the platform because it's a new thing for us. And just thanks again for having me on having me here today. Thank you guys.
Well,
I see
thank
some
you,
questions
Ross.
here, but I'll maybe take some live questions here from you guys, and then I'll go down to the chat.
Yeah, Ross, I just want to highlight, I really appreciate you coming on, and something I really learned. I think we all learn about B lines, A lines, and so on, but you highlighted the intricacies of the pleural line and the subpleural consolidations, how they can help you decide between CHF and maybe an infectious process. So I really appreciate you bringing that. That definitely added to my learning. So I appreciate you bringing this case. Somebody
Absolutely,
mentions
my
what?
pleasure.
Thank you. What POCUS resources do you recommend?
Yeah, I think there's many great free open access POCUS resources. So I'm a huge fan of NephroPOCUS done by Abhilash Kortala. There's great resources on volume status, integrating this in really thoughtful approaches. I mean, core ultrasound, many of the podcasts, POCUS 101, ultrasound gel podcast. Um, there's just many FOAMED or free open access medical education resources out there. And yeah, without being able to name them all, if many of them are so good, and they'll certainly get you started. But I think the thing that you really need to kind of take it to the next level is the local mentorship, whether that's kind of officially, unofficially. If I was going to learn POCUS from scratch, I would probably start by going online, finding some resources. I'd find some sort of local course to kind of give you that crash course, hands-on acquisition practice you need. But then I would really try to integrate that with a mentor or somebody in my local institution who can help me grow from there. Because if you don't use it and have feedback on it, you will probably have attrition in your skill set. I would encourage a POCUS elective if there's one available in your institution. If not, we have international POCUS electives here in London all the time. And so we have a critical care ultrasound service that runs 365 days a year. And actually, that's not true at all. I don't know how many days there are because it's only Monday to Friday, but it runs most of the time. So we always love having people come as well. So those would be my recommendations. I see a comment on, do I use ultrasound for JVP? Interesting. So I do not use ultrasound for JVP in the traditional sense that you would think of. So measuring JVP height and using it to kind of visualize it. Instead, I look at other markers of venous congestion in the abdomen. Vexus score, I talked about this a little bit on the last time I was on here. But I actually have looked at the internal jugular waveforms as a surrogate for venous congestion. And so we actually just published a paper looking at essentially stratifying patients based on cardiac output on ultrasound and markers of congestion to recreate the Diamond Forrester classification for heart failure for kind of shock etiologies in the emergency department. And that was based on jugular Doppler morphology, but not height itself. So I think it's an area of future research, but not ready for a prime funding.
And just to answer a question, yeah, we do have patients in the hallways here in the US as well, just like Canada, when we're filled to the brim. POCUS training is becoming more and more ingrained in US residency training. So the ACGME did issue a paper on mandating that POCUS training be adopted by all residency programs. So yeah, and any of you entering US residency programs will see that it's becoming adopted more and more by all levels of programs, from academic to community programs.
Yeah, that's the hope. And thanks for helping spread the word here, because really it's just a matter of showing people the potential value of POCUS, and then people will go out and find the opportunities that are their context appropriate. And so I think this is the first step, is making people aware that this is really the future of bedside assessment in my mind, and we're only having increasing evidence to support it. And that's something that many people have commented on is, well, where's the evidence for that? Where's the evidence for POCUS? And for many years, it was, well, like, it seems pretty cool, but we actually are generating high quality evidence now that it does change our management, it changes outcomes, it changes healthcare resource utilization costs. And so as that evidence base grows, I think more and more people are going to support its adoption into hospital systems. So thanks for your part in that.
And also I appreciate your part in that. And for those that are here, just going on YouTube and looking at CPS POCUS VMR, you'll see Dr. Prager's previous Vexus scan episode and many others from Dr. Gigi Liu, Ria Dansel, Sanjay Patel, everybody. We've had a good number of people feature, and you could pretty much learn the whole of theoretical lung ultrasound and cardiac ultrasound and so on from all those videos. So just want to highlight that.
And maybe I'll give one more shout out to Western Sono. So that's the ultrasound platform hosted at our institution that has many great lung ultrasound videos, echo videos. And we're launching a new series of blog posts specifically looking at lung ultrasound and kind of the cross-sectionality between that and AI. So hopefully that'll be of interest to people as well in the near future.
Amazing. Thank you so much for all the insights and for teaching us. It was a lot of good comments in the chat. And thank you everyone that connected. We will end the first session that we have for POCUS VMR, and the year is just starting. So we are going to go for much more. And thank you, Ross. Bye-bye.
My pleasure. Thanks for having me.
Okay, bye everybody.